Hi everyone, it's Konstantinos Valavanis broadcasting from my home in Athens, Greece. First of all, I hope you're all safe and well and coping the best in this incredible situation, the coronavirus. Although I'm not a big fan of webinars and social media education, I'd like to take this opportunity, the lockdown, and share with you parts of my presentation on the transition zone, presenting you the Marginal Migration Concept. I hope you will enjoy, and most of all, I hope to see you all very soon in person.
The transition zone. It has to do with hard tissues, with the bone. It has to do with the soft tissue. And of course, it has to do with the prosthodontics. We should never forget that, because even if surgery is perfect, if the restorative dentist is not paying attention to what happened in surgery, you will never have a sound result. And moreover, with restorative, with prosthetics, we can improve the surgical outcome. But let's focus first on the hard tissue, because there's a lot of discussion and a lot of confusion of what's going on nowadays. We hear a lot about the labial bone. One question is, will it resorb? Let's follow logic, biology, and anatomy to see if it's going to resorb. We have three sources of blood supply. PDL, the periodontal ligament, is one source of blood supply, the bone marrow, and the periosteum. These are the three sources of blood supply which will keep the labial bone intact or not keep it intact. Periodontal ligament, we know that once we extract the tooth, we lose this source of blood supply. Bone marrow, we know that 90% of the width of the labial plate is less than 1 millimeter. And from this 90%, 50% is less than half a millimeter. So as you can understand, there is no bone marrow, especially on the coronal part of the labial bone. So this source of blood supply also doesn't exist. The only source we have is the periosteum. And if you see histologies, you will realize how poor buccally this blood supply is. So actually, this coronal part of the labial bone is prone to resorption. We have to treat every case like it's gonna resorb. How fast? As I've told you, the best term to keep in mind is a tooth-dependent tissue. So you make the extraction, it will resorb. So we need to do something in order to preserve or mimic or protect our graft and our implant in place. So what about the gap size? Another myth. Everybody gives you a number. You know, most of the numbers in implant dentistry are good because we use them as guides, but they're average numbers. Average numbers are for average performance. So gap size, the answer is the bigger the better. The answer to how big the gap size is how much bone you want buccally to your implant. So nowadays, we use narrower diameter implants, even for central incisors and for canines. 3.5, maximum 4 millimeter diameter for the aesthetic zone, because we have more space, so more space for bone buccally. Another very important, most probably the most important issue, where should the implant be placed? We hear palatal positioning all the time, palatal positioning. Palatal, it's a wrong term. What needs to be palatal is not the implant. It's the upper third of the implant. Needs to be on the palatal wall, leaving this gap. The rest of the body of the implant needs to be placed. All these three positions that you see are correct. So the rest of the body should be placed according to the anatomy we have. It's 90% of everything. I say 90% of everything because it's 90% of the success, and it's 90% of everything because 90% of the failures, if not 99%, in the aesthetic zone is just because the implant is in the wrong position, especially buccal palatal. It's not because we didn't do a connective tissue graft. It's just because the implant is in the wrong position. And then we have to go to bigger surgeries, remove implants, bury implants, a lot of frustration and so on. This is why guided surgery, especially in the aesthetic zone, in more simple cases, is important and helps us a lot. So we place our implant, and what we do differently is that we will place a membrane in the alveolar. Many people say, oh yeah, that's what Tarno did. No, it's not. Dennis Tarno showed that we put a membrane in the alveolar when the buccal plate is absent and without an implant. Here we are placing the implant and the buccal plate is present, but we know that it won't be present long term. What's the benefit of the membrane is that we can graft supracrestal. And we can graft supracrestal even on thin tissue biotype. What we do is we utilize a membrane. I like pericardium membranes, which are a good barrier for at least 3 months, and we graft this area. Now, if you're using an implant system, and you should use an implant system, the other systems shouldn't be in the market. With a more tapered connection, then you can graft even on the transgingival component and the bone will stay there. It's very important to understand that conical connections are better than flat connections. Everybody knows this. And like I say, everything needs to make sense. Look at the companies. They are all switching to that, to more stable connections, because they know it's better. We have 2 solutions. Let's forget the aesthetic zone for periimplantitis today, because we cannot treat periimplantitis. A dear friend of mine, Jafar Mouhi, Professor Mouhi from Morocco, who's involved with Albrechtson Group in Sweden, they tried everything to clean a contaminated implant surface. Nothing works. So whenever an implant surface is contaminated, we cannot do surgery to have reosseointegration. It will never happen. So we have to find ways to not to have periimplantitis. There are 2 ways, because mainly we have this problem in the posterior area. And, 80% of our daily praxis is the posteriors, not the anteriors that I will show you today. We either use a transgingival implant, or we need, like any ridge here, a conical connection to go deeper in the bone. Subcrestal, 1 millimeter, 1.5, 2 millimeters, no problem. It's a conical connection. We won't lose the bone till the first thread. So exactly the same in the aesthetic zone, that we go deep to place an implant, we need a more stable connection implant. Now, what options do we have after we make the extraction? We can extract and wait. We can extract and graft. We can extract and place our implant immediately, or we will extract, place our implant immediately, and load immediately. Of course, we graft. We always graft, right? Now, the first option is for universities, not for private office. You will lose the patient. No actor, no wife of the mayor can wait 2 years to get a crown. So Sometimes you have a huge infection, I understand. You need to spend a lot of time to clean this infection and graft. Some people say, don't place the implant. Whether you place a graft or an implant, we know that it needs to be a clean area. So it's very rare that we extract and do nothing. Very rare. And it's more complicated afterwards, as you will see next year, to rebuild everything. Everything is built, and I like to keep it like this. Not lose everything and then try to build it up. It needs a lot of skills that I don't have. So let's see some clinical cases from A to Z, okay? The patient shows up, he's a 35-year-old male and has a problem with his right central incisor. As you see in the radiograph, it's completely resorbed, so there is no way to shave this tooth. How do we start? We start with something which I learned from Christian Coachman many years ago, and today they're so beautiful softwares, to communicate with the patient. I still do it. My assistants play with this program, the DSD from Christian. When I have to talk to the patient, I do it simple. So I have a big screen, I have my patient, and I have lines. I tell him, look, the margin, and this is also for my planning and my eyes, is 0.5 millimeter more apical, not to our favor. I show him that he has a shorter tooth and 2 diastemas. This is the most important thing, so that you convince the patient and also that he realizes that he needs to decide about certain things before we touch him. So if we have to close the distal gap on this case, it means that the central gap will be bigger. The patient asks, what do you mean? Why? And then you draw this line and you tell him that your tooth, which has a problem, is as wide as the neighboring incisor. So we have 3 solutions. One solution is we move the implant more distal, we close the distal gap, and you have a bigger central diastema. The second option is that we make a crown which is bigger and wider to close the gap on the distal gap of the right central incisor, and try to play with dental technicians' illusions to make the tooth look thinner. But we know that the central incisors are very difficult to hide. And the third solution is to place a laminate veneer on the neighboring incisor and make both teeth a little bit wider and have a smaller diastema. So you see the fistula we have on the distal aspect, a high smile line, so we cannot fail, because we fail a smile for his lifetime. This is how we start. So every step is important, so please pay attention the next 5 minutes. The first thing we do is we take a 15C blade, or you can take an ophthalmological blade, whatever you like, and we go further to the mucogingival junction, and we create a pouch which is big, as we would like to place a connective tissue graft, but we extend mesiodistally to the neighboring teeth in order to have elasticity in the tissues. Don't expect to see that macroscopically, that you pull the tissue down, because there are no vertical incisions. But definitely you have more elasticity there. After that, you see I utilize tunneling instruments to extend it, and then we will remove the fractured root, clean the area. Afterwards, we will utilize a pilot drill, and if I don't have a guide, I still like to use osteotomes, not to increase the primary stability, but to have an instrument which is this long, without water, straight and slow. So if something is wrong in my positioning, it's very, very obvious. The more you extend, the more obvious a wrong direction is. And because 90% of the failures are badly placed implants, please, these are the 10 seconds, the pilot drill, that we need to be very careful and place it good. And if you use the pilot drill and it doesn't look perfect, don't think it will get perfect, because after the pilot drill you can correct. After the second or third drill you cannot. So it's very important to pay attention to this osteotomy and the first steps. Then I will place a Megagen implant, any ridge, as you see here. Place the final abutment. It won't be the final, but I don't use provisional abutments. I don't see the reason. I use a final abutment and then utilize the membrane. Now, we take the membrane and, as I've told you, we place it not in the pouch we created, but in the alveolars you see on this sketch. What we do as a trick, which has absolutely no biological meaning, but it helps very much mechanically to graft, is we make 2 cuts to the membrane, as you see on the left side of the screen, in order to place it like this. Because while grafting, you have total control of where your membrane is. You don't squeeze it in with your packing instrument or the implant probe, which I like to use, packing the bone. So, no biological meaning, but it's very, very practical to place the membrane like this. And then you will utilize, as you see here in this video, the graft material. Use something non-resorbable in the aesthetic zone. Unfortunately, it's still the golden standard in the aesthetic zone. We care more about the aesthetics than biology. And of course, we don't use non-resorbable materials when we have a sinus lift or things like that. So according to what we need to achieve, we use also the bone substitute materials accordingly. But there, I don't want to have a resorption, and I want a material that is stable for that purpose. So after that, you see the radiograph, you just fold these 3 ears inside, one buccally and the other 2 mesiodistally. You can cut them if you want, okay? But I find it easier to unfold them like this than to cut them, because many times when you try to play with a membrane, you might pull it, you might destroy it, and so on. Plus, mesiodistally, it protects better your graft. The next very important step, and as I've told you, I will show you not befores and afters, because for me this is zero information to you. And I hate that. When I see befores and afters, look how great I am. I don't care. And since I was a young kid, eager to learn dentistry, I said, okay, he's a cool guy, but I learned nothing. So every step is important. If you skip a step, it won't be the same. And it's not fair to show befores and after. You lose your time from the office, and you just go out and say, yeah, this guy, the Greek guy, is a cool guy. Or if I was lecturing in Greece, you would think, let's send him the patient. No, that's not the way to do it. So, suturing. Never suture conventionally over the margins and over the papillas. Because whenever you do that, you push everything in and up. So what we do is we utilize more centered and 1 to 2 millimeters above the margin, 2 vertical mattress sutures. Okay? Even if we do flaps, I utilize these sutures. So, after doing this, we will utilize the first provisional restoration, which can be from your wax-up or from the initial situation. If it's pleasing, you use a rubber dam and you place the first provisional restoration. What's different in what we do? The difference is that we do not support the soft tissue with provisional restorations. We support the margin with the membrane and the graft, and we leave a gap from the soft tissue, as you see here, which is a big gap if you can visualize it three-dimensionally, because it's shorter and the implant is more palatal, so it's a big gap. This is after surgery, and this is what always happens in a matter of days, if not hours. You win tissue non-surgically, always. And the soft tissue grows down and in. Whenever you create a void in between the periosteum and the epithelium, and you displace the epithelium, this void will be filled. And because we leave space, the soft tissue is also thicker, as you see here. Another case, the same, thin tissues, thicker tissues. Another case, try to imagine the gap three-dimensionally. It's big. The result, three-dimensionally. You see how much tissue we win, not only vertically but also horizontally, without doing anything. Just by mobilizing the soft tissues, leaving a biocompatible surface to the soft tissues, and by allowing it to grow. It's like doing ortho, guys, because everything makes sense. We extract a tooth which is here, and we place an implant more palatally. The soft tissue, if you give it the chance, it will grow down. It's in ortho when we have procline teeth, the sexy smile that many girls have. We correct it, and we end up with a worse result for them, a gummy smile, because whenever you push the teeth in, the soft tissue comes down. The opposite problem when some orthodontists try to close the overjet by moving teeth of the lower jaw more backally, and then we have huge recessions. We know this from teeth. It's not magic. We just need to give space to the soft tissue to grow there, okay, with perfect color properties. So, this is the marginal migration sketch. You see the first, we do the tunnel, then we place the implant according to the anatomy of the bone, the membrane in the alveolar, the bone graft, and the vertical mattress sutures. 2 vertical mattress sutures are enough in order to give a tone and attention to this area. Now, the first provisional restoration should be screw-retained or permanently cemented, not provisionally cemented, because we all know it can be dangerous in the early healing phase for the implant stability if you have decementation. So, after doing it, I cut it, remove it, and here we are, without doing anything complicated. It's a very, very pleasing result. 99% of us would take an impression at this stage and allow our technician to sculpture the plastic soft tissue mask in the lab. This is many times not predictable, guys, because the soft tissue mask, whenever you trim it in a plaster model, you reduce the width in order to place a wider abutment. It has no effect in the vertical dimension of the soft tissue, meaning it stays there. It doesn't matter how thin, it's plastic. Then you take a very wide or a wider or a bigger transgingival component, place it in the mouth, and all of a sudden you push out, the soft tissue comes up. So the technician can't control 100% this situation. He doesn't know whether it's thin tissue, whether it's thick tissue, and so on. And what we do with easy steps to make it more predictable, everybody can do. You just go on, choose your final prosthetic platform, your final abutment, make a second provisional, which we call transitional provisional, even from prefabricated crowns, as you see here. You reline it, and then after doing it perfectly to the margin, we go, this is a vent, which is a nice trick I learned from Nichan, because it allows the cement to escape there and not to your surgical site. We do this also on root canal treated teeth. So the hydraulic pressure comes out of the vent if you do cemented. And this is how it looks. And after 2 weeks from here, we go there, which is more predictable. Now we take the impression or the scan. Now all the technician that needs to do is support our architecture. He doesn't have to improvise. And the technicians are artists, guys. Most of the ceramists, they don't really deal with the abutments and preparing them and so on. So the best way to deal with these very good technicians is to let them worry about the color and the shape, okay? After you've done everything for the soft tissue. Here we did it digital. It's a new trend. It works very well with implants. With pros, they still need some things to improve on full arches, on very thin veneers. Here you see the neighboring tooth is prepped, like minimally prepped for a very, very thin, a 0.2 laminate veneer in order to minimize the gaps, as we were discussing with the patient prior to surgery. You see the minimal prep, also on the digital pictures, and this is what? This is a solution to avoid cement, and also a solution for the technician to control, because it's not easy to have a veneer on a natural tooth and a crown on an implant on two central incisors with a high smile line where you see the margin and the connection of the soft tissue with the ceramic. It's not easy. So he will create, I'm blessed to have a very talented technician. He will do a veneer abutment. And then another trick he does, which I named the surf veneer, because you see a small piece of ceramic that will close the vent, and it's like a fin of a surf. So not to have a stress with my cement in terms of color properties. So it will be sealed with this fin, and this helps a lot. Let's go back to the case. You see the minimal prep, the veneer cemented on the neighboring incisor, and the final result on two central teeth, which is very pleasing thanks to my technician. Another message I always like to give out is, please, don't do 50 veneers upper jaw and 50 veneers lower jaw. It's malpractice and overtreatment. We are not businessmen. So when you see the face of this young kid, it's pleasing even if we don't have veneers on the lateral. And perfection is only nature. And I'm sure you will see in the next days with the excellent speakers that are in the program. Nature is perfect, because it's not perfect. So let's see how this concept works with teeth. A case that you all have in your office, an old crown. This is an orthodontist that came to me for a connective tissue graft. A crown was done by a prosthodontist at the time, was placed subgingivally, and he has a recession. So, first step, you see the positioning of the tooth. It's a little bit more buccal. He has a dark abutment that we will treat mechanically. I prefer to do it like this than chemically, because we might have resorption. You see here how it looks and where the margin is. We will clean it mechanically and do reverse crown lengthening, meaning we will go on, remove the margin, and create a very thin new margin. After we do that, we will mobilize the soft tissue. We will make a pouch, extend it to the neighboring teeth and further to the mucogingival junction, and make 2 vertical mature sutures. Provisional restoration, look how it heals. You can't see the sutures because the tissue thickens. And this is how it further heals, and this is where we are now. Now we can do our final restoration. This is how we communicate with the technician. And from there, we go here with no color property problems and with something that everyone can do. Not complicated dentistry. Every case has the solution, which is more practical than the obvious solution. This is 5 years from a picture he has sent me. You see the stability that we have on a compromised initial situation. Thank you very much for your attention.